Everyone online, hopefully you can hear me. Put something in the chat so Renee knows that that's working. Any response? We're good? Okay, good, great. Yes, we'll get to that part. All right, everyone, thanks for coming. This is the April Mercy M&M. Great turnout in person. Really glad that you're all here because it's super awkward when there's just like 3 people and I just like keep staring at them. Right? Yeah. Just as reminders, you can register for all the M&Ms at trinityhealthofany.org/EMS-classes. We also post reminders on our social media, which unfortunately have different handles. Instagram is TH of any EMS, Facebook is Trinity Health of any EMS. So that's all of our stuff is on the website. Get the reminders there. And new as of the last few weeks, if you scroll down to the bottom, there's a link to recordings of the sessions. There's a playlist on our YouTube channel. It is going to be only the lecture part that I do at the beginning. It won't have the full case discussions, obviously, because it's a public YouTube playlist. But if you missed something in the lecture or someone mentioned something that happened in the lecture and you want to go back and watch it, that's available for you on the same website where you register for them. So in-person participants, please scan to participate. If you are participating remotely, Renee will be triggering the poll questions to pop up in the chat. But if you're all at a station watching together, it's easy for you to just scan the QR code for you so you can participate. Go ahead and do that. If you just have it pulled up on your computer or something and you want to respond to the polls on your phone so that you can keep doing dishes or whatever else you're doing while you're watching, that's fine too. So either go to the link or open the QR code, whatever is easiest for you. The more people that do the QR code or the link, the better, because then we're all on the same voting thing and we can see what each other's saying versus kind of comparing to what the polls is in Teams. So we'll start with the first question. How you feeling? Making sure it's popping up on your phone. Response. Oh, who's a 1? That's sad. I mean, lo siento, but okay, good. 3 to 5. That's better than I would expect. Okay, great. So last time we've been covering cardiac arrest last month and this month. Last month we were mostly focusing on CPR, airway, and IV versus IO. And when it came to CPR, we talked about the use of mechanical CPR and mechanical compression devices. We talked about how they're actually associated with worse outcomes generally. And that for the average patient, for the average resuscitation where you're not trying to move them, doing good team-based CPR is probably better. That the only clear indication for mechanical CPR is transport. That 30 to 2 CPR is probably better than continuous CPR. The data on that is still coming out. That's even with an advanced airway in place. So choose wisely in terms of your compression ratios for who you're going to put the Lucas on because it's not a free lunch. And then we also talked when it comes to airway. The research on that basically says do whatever you're comfortable with as long as you can get it the first time. You don't have to stop CPR. And whatever you do, just make sure you use waveform end tidal so you know that it's in and you can monitor the end tidal throughout the recess. And when it comes to IV versus IO, there's probably no difference for IV versus IO. And for cardiac arrest, there's probably no difference for upper extremity versus lower extremity IO. Now, keeping in mind that the upper extremity IO does have a faster, quote, better flow rate, but for all 10 cc's of that milligram of epi, that doesn't make a difference. It might make a difference if you have a septic patient who you're trying to give large volumes of fluids to, or in the future, if you're transfusing blood, upper would probably be better than lower. But for the small volumes that we're giving in cardiac arrest, it doesn't appear to make a difference. So it's like I tell people, it's like when you go to a busy restaurant, do you want to sit inside or outside? First available. Like just whatever you can get first, use it. Doesn't seem to make a difference. So this time, let's move on to talk about defibrillation, transport, ROSC, and some of the cutting edge research that's kind of going into this with pre-hospital recess. So we'll start talking about defibrillation. What is, you think, your best pad placement? Anterolateral or anterior posterior? Okay. So we got people mostly voting for, so anterolateral has a majority. Why? Someone who said anterolateral, tell me why. Why do you think that? Why is it better? Come on, 70% of you said that, so someone tell me why. Yeah. Okay, good. Okay. So it kind of makes anatomic sense that it's going like in the same direction as the heart. Okay, anyone else have a reason for anterolateral? Yeah. Okay. Okay, good. So again, with like kind of the positioning and the anatomy, one argument for anterior lateral is that it's easier to do. Okay, you can do it when the patient's laying on their back. You're like, speaking of first available, how about it's the one that I can do with the least amount of effort? Okay. Someone who says AP, why do you say AP is better? Okay, less tissue to go through for the actual defibrillation. Okay, anyone else? Okay, less physical distance between pads. So maybe this is electrically better. Okay, good. So everyone's heard of the study by now. This is the DOSE VF trial that came out of Canada. This is where this is the big study on double sequential defibrillation that came through and that everyone's been talking about now for a couple of years. So they tested 2 defibrillation strategies, well, 3 technically. So there was standard defibrillation, which is anterolateral. There was vector change, which meant after we try anterolateral, we're going to switch AP. And then there was dual sequential, which is you have an AL and an AP set of pads on, and you get shocked almost simultaneously. Which is this one. So you got 2 defibrillators versus just switching pad positions. Okay. And this is the actual training video that they showed paramedics from the study, so that you understand like exactly what they were doing for dual sequential defibrillation.
This video will show how to perform a double sequential defibrillation using 2 dual X-series monitors.
Stop CPR, analyze the rhythm. Patient is still in VF, continue CPR, we're charging 200.
After your third shock has been delivered, prepare the second X-series for double sequential.
Okay, stop CPR, I'm clear, you're clear, everybody's clear. Third shock delivered, the patient's now in the DOSE VF double sequential arm of the study. After your 30 compressions and 2 ventilations, we're going to apply the posterior pad.
Apply the posterior defib pad of the second monitor during the first compression pause. Remember to remove compression sensor pump.
Hold the patient, please. Okay. After your next 30 compressions and 2 ventilations, we'll apply the anterior pad.
Apply the interior defib pad of the second monitor during the second compression pause. Complete the full 2-minute CPR cycle.
Stop CPR. Analyze, the patient is still in VF. The first double sequential is going to be done. Continue CPR. Charge both monitors to 200. Stop CPR. I'm clear, you're clear, everybody's clear. Shock 1, shock 2. Continue CPR.
Complete the full 2-minute CPR cycle.
Okay, stop CPR. Let's analyze the rhythm. Patient is still in VF. Continue CPR. Charge both monitors for the second double sequential shock. Okay, everybody hands off. I'm clear, you're clear, everybody's clear. Shock 1, shock 2. Continue CPR.
Complete the full 2-minute CPR cycle.
rhythm. Patient still in VF. Continue CPR. Charge for the third double sequential defibrillation. Okay, stop CPR. I'm clear, you're clear, everybody's clear. Shock 1, shock 2, continue CPR.
So that's what they did. So on the they'd after. So, oh, by the way, people that are in person, pizza's here, so you should all grab some before it gets like cold. So this is like your one chance at EMS to have food while it's still warm. So like go grab it. So what they did was on the fourth shock, they randomized patients to either dual sequential or vector change or continuing with the standard pad placement. So both dual sequential and vector change had better survival than just continuing with the standard pad placement. So that raises the question, did vector change improve the outcomes because AP works better? So maybe AP is a better defibrillation strategy, and maybe we should be doing AP up front. There's research being done now because so they were randomizing patients on the fourth shock for dual sequential. Now they're trying dual sequential like earlier on. Like, do we have even better success to try the dual sequential even earlier in the resuscitation? You okay? Have a question? Mm-hmm. They continued, I think at that point they transported the patient. Yes. Yeah. Yeah. Basically from the fourth shock on, they're just going with whatever strategy the patient was randomized to. So it seems like AP might be better. And they may be doing so, or you may find out with current research that dual sequential defibrillation works better if it's done earlier on. Also, you notice that they are pausing, checking the rhythm, then charging the defibrillator, and then pausing the shock. It is totally safe, and I would recommend that you charge the defibrillator leading up to the rhythm check. So the second you identify the rhythm, you can shock it. If appropriate, otherwise you can dump the shock. The other piece with this, obviously, is what do the manufacturers say? Physio, maker of the Life Pack, says don't do it. It's off label. You'll void the warranty. We won't support. Zoll, obviously the one that was used in the trial, says it is off label, but if you're going to do it, this is how you do it safely. Just make sure the pads aren't touching and you don't do it simultaneously. You noticed it was like one then the other, but they were doing that's an important piece of that. Although in other research that's come out looking at this, they found that the closer the shocks are together, like when they're within like 100 milliseconds with not like the best. So I strongly suspect that we're going to see products in the next several years that just have two pad outputs, and it'll be one machine that will just do it on its own. Good question? Yeah. So the Zoll, when you select the joules, it measures the thoracic impedance and adjusts the shock to match it. So after you deliver a shock on a Zoll, 200, and number one is the maximum. And number two, after you shock, you'll actually see how many joules the patient actually got, so that it takes into account the difference between shocking me and shocking a 60-pound grandma. I like Zoll monitors. I mean, everyone just like hates on them, but what? Right. Let's talk about our decision to transport the patient. When do we transport the patient? So when do you transport a cardiac arrest patient? Okay, as quick as possible after your 20 minutes resuscitation or after you get ROSC if you get ROSC. Okay. Right. Someone who said after 20 minutes, then you're going to go tell me why. Maybe. Course. Okay. Yep. Yep. Okay. Yep. Mm-hmm. Mm-hmm. Okay. Okay. So you run it for 20 minutes, particularly to kind of see where we're going and then maybe involve EdCon. Particularly, it depends if this was unknown last well, they're 85 with 100 medical problems and it the whole time, right? Or maybe they had VFib one time and you're like, so it's not 20 minutes of asystole, right? You sure that was VFib? You weren't just scratching the defibrillator pad? Um, Someone who says only if you get ROSC. Tell me why. Yeah. Good. You can't do good CPR while transporting. You know, someone from Stryker would like to have a word with you about the Lucas too. But okay, good. So the research on this is also pretty clear. Agencies that tend to work the arrest on scene for longer have better outcomes. And that probably is because you can't run an arrest well while you're transporting the patient. So we do better when we just stay on scene for longer. So you can see here that the less often you transport a patient in cardiac arrest, the better they tend to do. So you see kind of big differences here, just like more often that the larger percentage of patients that an agency transports, the worse neurologic outcomes the patient have. And that probably has everything to do with the fact that we can't do this stuff effectively on the move, that we're best if we just park it and do everything correctly for a while, we're going to get the best outcomes. Then really only transport if we have ROSC. So in terms of our termination or resuscitation criteria, they should generally be working patients on scene except for pregnancy. I don't know why drowning is in there. Probably because they're usually going to be hypothermic, but drowning, hypothermia, penetrating trauma less than 15 minutes from a level 1 trauma center. Why do you think those are exclusions to the field termination criteria? Okay, so baby might still be viable. Okay. Any other thoughts? Yeah.
Trauma. I restarted.
Okay, they need a surgeon to do what? Okay, stop the bleeding. Okay. So the point is that pregnancy, hypothermia, and penetrating trauma within 15 minutes of a trauma center all have something that we can actually do at the hospital that isn't done in the field. So for a pregnant patient that's in cardiac arrest, we can do a resuscitative hysterotomy, aka a perimortem C-section. We can cut the baby out and see if mom gets ROSC and see if baby lives. Okay. Hypothermia, profound hypothermia, we can put the patient on ECMO or take them to the OR and put them on cardiac bypass while we warm them up to see if we get ROSC. Penetrating trauma, less than 15 minutes from the trauma center, we can do a thoracotomy. We can crack the chest. We can try to fix the problem. So the point is, the reason that those are exceptions is because there is something different we're going to do at the hospital. Otherwise, hospital grade epi, no different than EMS grade epi, right? There's no miracles for the standard medical arrest. And the other exception is going to be your persistent VF or VT patient. So by the time you get to the fourth shock, now we're thinking, okay, what else could be going on? Like, what are we missing? Because again, it's unlikely, but at the hospital, there's still the possibility of doing something different, taking that patient to the cath lab while they still have CPR and going to Lucas, or getting put on ECMO or bypass or something. But again, it's not like there are other procedures that we can do for persistent VF and VT. So after we've kind of exhausted giving amio and lidocaine, we might give esmolol, which is actually a beta blocker, because maybe now we've gone a little bit too much the other way. Why do we give epi at all in cardiac arrest? What's the thought process? What's it supposed to do? Okay, so vasoconstriction and increasing contractility. So it's actually mostly for the vasoconstriction. What we're trying to do is make more resistance so that when we create cardiac output with the CPR, that we're creating perfusion pressure for the brain and for the coronary arteries. That's what it's supposed to do. The extra cardiac excitability is probably more of a bad side effect, which is why after in the hospital, if I'm running an arrest and the patient arrests in the hospital, I'll usually not do more than 3 epi, especially if we're persistent VF or VT, because adding more excitability is not going to help. Okay, so at that point we may switch to a cardiac selective beta blocker. So esmolol is very beta 1 selective, so that is specifically going to be trying to calm down that VF so that we can maybe defibrillate the heart. There's also a maneuver called a stellate ganglion block, where we block the sympathetic chain, the sympathetic nervous system, usually on the left side of the neck. Again, trying to reduce that signaling to the heart to get it to calm down. I've not done it in a cardiac arrest yet. It makes me a little nervous because the first video I watched, they said, so your landmark here is to go just posterior to the carotid artery. I'm I see no way in which this could go poorly. So with the persistent VF, again, there's something we might do differently at the hospital. But for anyone that's just going to keep getting more epi, doesn't work. It doesn't work any better at the hospital. And in fact, we're probably doing a disservice by trying to transport the patient. So to review the field termination criteria, number 1, remember that if you start the resuscitation and then you find something that would have caused you to withhold resuscitation to begin with, you can just stop. You don't have to call. Right? So that's fire started CPR. You get there and you're like, bruh, that's lividity. Okay, you're done. Okay, you don't have to continue. But otherwise, it's worth noting that it says effective airway support, not advanced airway. So if you are able to effectively bag the patient the entire time, but maybe there was some trismus in the jaw, so you can't get an LMA or an ET tube, that counts, okay? So you can just say, I've been effectively ventilating the patient with good compliance, even though there's trismus in the jaw. The other thing is that this says 20 minutes of resuscitative efforts, not 20 minutes of ACLS. So the clock starts, let's say you get a BLS crew there first, the clock starts when they're doing CPR and getting the AED on, and then you get there and you're like, hey, how long are we total here? About 20 minutes. Especially now, this is also including the persistent PEA systole picture. We know at that point nothing good's going to come of this. So just be more conscious, I guess, of your time, and you can use that when you're calling in. So ROSC and some other information. Number 1, we are awful at feeling pulses. Research where they've put a patient who's on cardiac bypass in the OR, and they brought in paramedics and ER nurses, said, tell us whether this patient has a pulse or not. And they can take as long as they want to determine that. Literally a coin toss on accuracy, and they're taking, how long's our pulse check supposed to be? How long is it supposed to take? Less than 10 seconds. They're taking on average, for them to be sure, but still only a coin toss on accuracy, upwards of 30 seconds. So we're horrible at finding pulses. Also, so this is an ultrasound from a case that I was running. So this is the artery. This is the right leg. This is the artery, and this is the vein while CPR is going on. So where do you think what do you think you're feeling during compressions? You're feeling backflow from the chest compression, filling up the veins and going back and forth. So pulse checks, remember, and the terminology has actually been completely removed from ACLS since at least 2014, I think. They don't call them pulse checks anymore. They call them rhythm checks. So if you don't see an organized or what could be a perfusing rhythm, you don't check for pulses. You just stop and you're like, VFib, asystole, continue CPR. We don't need to check for pulses if it looks like VFib, right? We know that's not a thing. So let's talk about the ROSC EKG. How long do you think the EKG stays abnormal after ROSC? Because obviously you just gave them all kinds of epi and you're pounding on their chest and you shock them, so it's gonna be abnormal. So how long do you think it's abnormal? Abnormal. All right, so we got 8, 12, 20 minutes. Consensus seems to be hanging around 12. Okay. Okay. So a while. So this has also been studied. Mostly they're looking at STEMI. So if you get ROSC immediately and you do an EKG and it shows STEMI, how often does that go away if you wait? And how do those patients do? Okay. So it turns out that you get a lot of false positives initially, about a third. So if you immediately get, if you 12 lead immediately after you get ROSC and it shows a STEMI, don't be surprised if when you get to base state, they're not like, they're like kind of pumping the brakes and just getting a repeat EKG, because a third of the time it will go away and those patients don't actually have a coronary occlusion. And they do fine. They're going to go to cath, but this is the difference between wake up everyone that works in the lab, get them here now versus first thing in the morning. Okay. So there's no reason to expose the patient to the additional risk of going to cath immediately, and they just got ROSC, and so you probably shouldn't necessarily be giving them a bunch of heparin and all these other risks from going to the cath lab. So about 8 minutes is your cutoff between, if it's going to normalize, it'll most likely normalize around 8 minutes. So if you don't remember 8, you can remember 10, because it's a nice round, even number, that after about 10 minutes, the EKG will probably have normalized. So if that still shows a STEMI, so I'll still get the 12 lead immediately, right? Because if it shows nothing, cool, right? But if it shows a STEMI, let me repeat it once we kind of get loaded up after we have 5-10 minutes. Oh, it's changed. Then you can show them when you get there. You're like, hi, immediately showed STEMI. Now it's kind of gone away. So maybe that's just, all of the vasoconstriction from the epi or whatever else was going on. So let's talk about some cutting edge stuff. Keep in mind that none of this has anything to do with protocols. I'm just telling you about recent research that's been being done. Don't do this and say, Dr. Goebel said it was fine, okay? So things I thought I knew about epinephrine. Number one, that a rock can get ROSC with enough epi. And number two, that it doesn't increase neurologic intact survival, right? That we just get ROSC and we're making zombies, right? We're not saving lives and saving brains. To which Salt Lake City Fire Department said, hold my Diet Coke. So what they did was they initiated a protocol where, in addition to their standard ACLS, get an IV, push the epi, yada, yada, they did early IM administration of epi. So it was a higher dose. I want to say it was 5 milligrams IM. But it was still only the ALS units. So this wasn't like BLS was doing it earlier on. This was a medic on scene. Before you fumble around with the IV or the IO, you drop and give IM epi. And what they found was a little surprising to me. Anywhere between, if you're looking at neuro intact versus survival to admission or discharge, between like 4 and 5% improvement in survival, which that ain't nothing from the number of cardiac arrests we go on. 5% improvement in survival means you need to do that 20 times to save one life, which is not outside of the realm of possibility for the number of cardiac arrests that we run, right? Now, they excluded everyone that got ROSC after like 1 or 2 shocks, like where it's like, okay, obviously the epi wasn't like in long enough to have an effect, but for everyone else, it seems to make a difference. And so maybe the issue was not giving epi, but it was giving epi fast enough or sooner enough, more sooner enougher, most soonerist. So the Paramedic 2 trial is what everyone, and myself included, loves to quote when we're ragging on epinephrine and its efficacy. Now, the time from arrest to first epi administration in that trial was an average of 21 minutes. In Salt Lake City, in this trial in the IV arm, it was 15 minutes. And in the intramuscular arm, it was 12 minutes. So maybe what we're learning here is that you just need to go faster, right? They just need the epi faster, sooner, right? And so that has to do with the route. And so maybe what we'll see, some kind of auto injector that BLS can use, right? With the AED, and they get some kind of like high dose epinephrine up front. Or maybe we'll invent some sort of tactical EpiPen that the cops can keep with their AED. Or recently approved by the FDA was intranasal epinephrine for anaphylaxis. So maybe nasal epi will work. We don't know, right? But this is ongoing research that I find very interesting because I love to bag on like, whatever, the epi doesn't work any better at the hospital, epi, we're just making zombies, we're not making survivors, right? Maybe it's because we've been doing it wrong. Maybe we need to get it in faster, and that means considering different routes, increasing it to something a first responder or BLS can do. We don't know. Stay tuned. Okay? And then there's ECMO. ECMO stands for extracorporeal membrane oxygenation. This is a pump that has a specialized membrane that, even if the heart is not beating, can remove carbon dioxide and add oxygen to the blood. It's very similar to heart and lung bypass. Heart and lung bypass is what happens in the operating room. And ECMO is what happens outside of the operating room. They're different machines with different tubes that go in different places, but they're functionally pretty similar. ECMO pumps are designed to be used for prolonged periods of time. Bypass is only designed to be used for several hours during an OR case, but you can leave someone on ECMO for weeks if you have to. Okay. So the way that ECMO has changed the game, when cardiac arrest started, right? We didn't have anything we could do, right? This is where the term blowing smoke up someone's ass comes from, because we literally tried giving people tobacco smoke enemas to see if it would cause them to resuscitate, okay? Or racking people back and forth over a barrel, putting them on a horse and then slapping the horse so it rides away and like makes their arms like jiggle. Maybe that'll help, right? Right? And when EMS originally started, and it was really the mortuaries and the hearses that were coming to get you because that was the only conveyance that you could lay flat in. And so early EMS kind of extended that, and all ambulance drivers did was just bring them to the hospital, right? Even early paramedics, everything was Mother May I, right? When you watch Emergency, like everything is Mother May I. You got to talk to the hospital about it. But then we learned more about running the arrest on scene. We got defibrillators in the field. Paramedics will be able to do IVs, and then we have IOs. And so we became professionals at being able to run resuscitations in the field. And now the messaging I'm giving you is like, well, don't just come to the hospital, run it on scene, because the epi doesn't work any better at the hospital, right? And now we have the technology to be able to continue effective CPR and safely transport a patient who's in ongoing cardiac arrest. And for a select group of patients that are ECMO candidates, this appears that it may be their best option. And in some places in the world, they're already doing this pre-hospital. So this is the SAMU ambulance service in Paris. A patient getting put on ECMO in a subway station in Paris. That's not what I wanted to do. That's the ECMO, that's the pump right there. You can see the hoses with the blood heading towards the groin, because that's what they do. They put one in the femoral artery on one side, one in the femoral vein on the other. This is the same agency. By the way, this is doctors, not just medics. They're putting on someone on ECMO in the Louvre, right? And this has started to become a thing in the United States. So in the Minnesota Twin Cities area, it's been promoted by and is mostly done by interventional cardiology. So they have a unit that they've created that basically has a mobile cath lab on the inside where they can put a patient on ECMO, and they've had extraordinary outcomes. Also in Albuquerque, they have set up a special ambulance that they leave at the hospital. And so if there's a cardiac arrest, an ER doc will jump on the rig. The fire department will come swing by with the ambulance to pick him up, and they'll go to the scene of a cardiac arrest to put a patient on bypass. You can tell in Minnesota, they need to be fully enclosed. And in Albuquerque, they're like, just set up a tent. The weather's fine. They're like, what is snow, right? And in the Netherlands, they have created a system on the piggybacking on their air ambulance service, which covers the entire country, so that they can have any cardiac arrest anywhere in the country on ECMO within 30 minutes of arrest. The helicopter with the doctor will land and then put the patient on bypass, wherever they are, including a very picturesque field that appears to be at some sort of airstrip, probably because they're training, because that's where the airbase is. Yes, it does get cold there, which it's interesting because a lot of this, the progressive nature of this, has come from countries where it does get very cold because they're used to doing this for patients that are hypothermic. So these are the kind of major trials that have been done. The two that people tend to quote, the Yiannopoulos 2020, that's the Minnesota Twin Cities, where they had 43% neurointact survival in the ECMO arm versus 7% in the non-ECMO arm. And then there's the Prague study, where they found no difference in survival. But the very interesting thing about this is, so they again had that roughly like 30-ish% survival in the ECMO arm, but their non-ECMO survival jumped from 10% to 22% when they did the trial. And so ultimately there wasn't a statistical difference because they had designed the study for 10% survival in the non-ECMO patients and it jumped to like 20%, which they think is probably because when you implement an ECMO program, you have to make sure that you do everything about every cardiac arrest very well so that you can optimize the subset of patients that are ECMO eligible. And there's carryover benefit to the non-ECMO patients when you're still optimizing everything about doing mechanical CPR and access and the choreography that carries over to the non-ECMO eligible patients. But the bottom line here is that we have 35% on average neurointact survival at almost an hour of cardiac arrest using ECMO, which is astonishing, right? Like, who's running arrest for an hour and thinking, yeah, 1 in 3 they'll walk out of the hospital? No, right? Not even a little bit. So it's truly remarkable, the outcomes that we're able to get with this. And so I think that is probably the future. How that's going to play out, what the logistics are, no idea yet. Because I don't know if you've been to the ED lately, but they're a wee bit resource strapped. So putting patients, crashing patients onto bypass is not necessarily cards right now, but it's happening in other parts of the country. LA County has a protocol where they have cardiac arrest receiving centers. And basically they have criteria where if the patient meets certain clinical criteria, so based on age, risk factors, witness time, et cetera, they're like, this patient's an ECMO candidate. Instead of running the arrest on scene, they put a LUGAS on, they load and go. Okay. Boston also has a special project waiver for doing this for several of their ECMO centers, where they are similarly using criteria to expedite getting patients to a center where they can put them on ECMO. So I'm cautiously optimistic that this will end up becoming standard of care for a certain subset of patients in cardiac arrest, but we don't know exactly who that is yet. And we also don't know what that's going to look like, whether it's expediting getting the patient to the ECMO center or whether it's bringing ECMO to the patient. It's probably going to depend on, it's going to look different wherever you are, kind of like you've seen one EMS system, you've seen one EMS system. That's just the 40-minute mark. Let's take a 10-minute break and we'll come.